as Pete says, it's a fantastic opportunity for us to come together and talk about something completely different to arthroplasty, the complete reverse, preserving the knee. And although obviously I've mucked up the program by asking to go first, in fact osteotomy should be first and should set the scene for the rest of the talks, because alignment is everything. So I'd just like to thank Rags, who's coming later on this afternoon, my most recent fellow who's just been appointed at Guy's and Tommy's, and the other fellows and members of the research team, and also all the support that we get in Basingstoke from industry, with our registries, and with our research. And it really is key to all the things that we're talking about. If we don't get the alignment right, then the other procedures that we do want to do the patients are much less likely to work. And we can do it to retension ligaments to improve function, but obviously most commonly we use it to unload damaged arthritic compartments of the knee. So in terms of the algorithm, where do we start? And I mentioned at the very start of my lecture that really getting the alignment right is the first part of putting the jigsaw puzzle together in terms of treating patients' problems. And this, I think, is also Tim Spalding's slide in terms of what we should do. So get the alignment right, think about the instability issues and do the ligament reconstructions, deal with the meniscus, deal with the joint surface, and then obviously we need to rehab the patients, and that's from Verdonk. And this slide for Roman Sale, the current ESCA president, often gets shown by myself and others, because it's such an important message, and probably the key message from the talk is this is where we want to keep our patients in the repair phase. We want to avoid the reconstruction and arthroplasty phase for as long as possible. Our patients are living into their 80s. We know that joint replacements have limited lifespans, and also the outcomes are unpredictable. And this is where we should be making the effort to maintain patients in the repair phase. So we know with meniscal surgery we can excise or we can repair. And we're going to hear later on today from others about the options in terms of meniscal scaffolds and in terms of meniscal allograft transplantation. We also know that we can do things to the joint surface. We can tidy them up, microfracture. We can actually replace with the patient's own tissue, or we can use these new allografts, fresh frozen options that are available. And of course we have cartilage resurfacing opportunities, and then we start to move into joint replacement. We have these new metal and plastic partial replacements, and then we have the replacements that we're all familiar with. So to try and make osteotomy work a bit better, because it can be a painful operation, and it has always had historically a very bad reputation. And what we've been trying to do with this operation, as we've brought it into its new form, is to make it as minimally invasive as possible and make the rehabilitation as quick as possible for the patients. And we've done this by making smaller incisions. We now use a precision, what we call a precision bone wedge. We use these small plates and we use cryotherapy. And it is possible to use big and small plates through small incisions through an operation that can take 30 to 45 minutes in skilled hands. It's very important to have the correct equipment, and these are expensive. This Striker saw blade, the handpiece is expensive, the blades are £200, but you can see how it's not cutting my glove. And particularly on the femur, you can use your finger as the homen at the back of the femur to protect the neurovascular structures, and you can have complete safety knowing that you're not going to cause injury or harm because of this fantastic device from Striker. We used to use these big incisions, extensile approaches, and in fact Neil said that when he first started at Stanmore, one of the surgeons, Carl Nissen, used to just drive a sharp osteotome straight into the bone without making a skin incision, and that was how he carried out his osteotomy. And we've moved on to this Hanover approach, this from Christian Clay, this minimally invasive approach. And in terms of the landmarks, obviously this is not beginner surgery. So with osteotomy, it's important that you become familiar with the technique, and as you gain confidence, you start to move to this to smaller and smaller incisions into what you're comfortable with. So here I've marked out the back and the front of the tibia and the pes, and you can see the joint line above. I'm then going to mark out where I think I'm going to need to be in terms of getting the top of the plate and the bottom of the plate. So when we then obviously make our incision, we go down, do a superficial MCL release, which is really very similar to what we do during knee replacements, and then we place our guide wires. You can either place one if you've become very familiar with the technique, or initially we teach our trainees to use two as a cutting platform for the saw. Again, just to sort of reiterate that this is, I think, a key piece of equipment, and if you don't have it, get it in, try it, and once you've persuaded your line manager that actually having a neurovascular injury is potentially expensive, this is something that I'm sure they'll agree is a device that you can have as part of your armamentarium. We do a biplane cut, so that means we make the incision, the main horizontal incision, 70% of the way through the bone, or 75%, and then we make at an angle of 110 degrees. We make our ascending biplane cut, and we do this because we don't then have to worry about coming through the tendon. We have this lovely buttress of bone that will heal within the first 3 weeks and provide stability, and it really does. Alex Stauble's got some very nice work to show that, it also means that you only have this much of the bone that actually needs to heal as part of your working osteotomy. So once we've mobilised the bone with the saw, we can then finish off the osteotomy, and we very, very gently tap in the osteotomes, and in fact at this stage really you should be putting them in by hand. The osteotomy needs to be mobile, and you should really try and do that with the saw if you can. So we then came up with this concept of trying to use a laminar spreader without putting it inside the osteotomy gap, and this is obviously dying for an instrument to be made, and the foot and ankle surgeons have something that's reasonably useful for this. But you can see that by placing the laminar spreader onto the wires, it's not in the osteotomy gap, which means that we can place our bone wedge very easily. Now the question is whether or not we should fill the gap. Alex Stauble, he had more than 500 cases up to 22 millimeters, and he never put anything in the osteotomy ever, and he never had a single non-union. So the plates are designed to heal without any material, foreign or bone being placed within the gap. But there is a temptation from orthopedic surgeons to fill that gap. We want to put something in it. It always makes us feel better, and in fact there's good reasons why you should. So in Basingstoke, what we decided to do was take our femoral heads from our bone bank and use these to fashion bone wedges. And we can make these wedges according to our digital planning, so we can make them slightly bigger at the back, slightly smaller at the front, to maintain a trapezoidal space, so that the slope doesn't change. So we can actually use it as a tool to not only stop this from bleeding and act like a cork in a bottle, but also to provide its immediate stability and faster union. So in terms of placing the bone wedge, we use this sophisticated tool, and you can see how the laminar spreader is out of the way. Once the bone wedge is in, that's the operation done. So then you can take your wires out. You then have this window that you can work within to put your plate in, it's so much easier than having a laminar spreader at the back of the osteotomy and fighting with that for the rest of the case. So there are lots of different plates that you can use. This is the NuClip Active Motion 2 plate, which we've been using. I'm a designer. I made a few comments as a designer surgeon, but it's a nice plate because it is actually stronger than Tomafix. So it was tested by Dietrich Pape. They're the go-to guys in Luxembourg, and NuClip took their plate there, and they've done it for iBalance, Tomafix, Peak Plate, and they've now done it for NuClip Active Motion. And actually, it outperforms the Tomafix in terms of its strength. And Dietrich's about to publish that paper. And it's obviously again facilitates a smaller incision, and it's can be done MIS. We then let the tourniquet down, elevate the leg, give tranexamic acid, and then everyone is encouraged to have one of these. Obviously, in the NHS, you have to try and sell it to the patient. Private patients tend to just be quite happy to rent one of these, and I think this makes a huge difference to the outcome. So here's a typical case, and this is really, a lot of this meeting is based around these types of patients. This referred in by another knee surgeon. You can see a failing medial compartment, some patches of grade 4. There's definitely some life left in this knee, and this guy's a very fit, athletic guy who wants to continue with his sport. He wants to continue to be active, and he's certainly not ready for any kind of knee replacement. And what he's saying at the moment is, I haven't taken a paracetamol yet, and I don't understand why, because of what you did to me. And I think that's a combination of the minimally invasive approach, the cryotherapy, and the steps that I just took you through. Here's a grade 4 case, 42. He's got bilateral medial osteoarthritis and night pain, and he had a double osteotomy. On one side, this was a peak plate. On this side, we did the deformity analysis, and I didn't want him to be doing this at 3 weeks, but he, sometimes you get these patients. He was off his crutches when he came to see me, and patients can perform well early with this particular operation. And actually, his pain scores at a year were fantastic. That he had a VAS score of nothing. Here's a bilateral simultaneous case that we did about 18 months ago at Basingstoke, 47. If you look again, he's varus. He's got early degenerative changes. On the arthroscopy, we can see the failing compartment. So on the left, we do a bone wedge MIS. On the right, we do the same simultaneously, and this is the patient. The next day, we allow him to fully weight bear. We don't obviously encourage the patients not to do too much for the first couple of weeks, but he was very comfortable and went out the door the next day. So this is a good friend of mine. The reason why I put it into this presentation is it shows that this is a knee surgeon. Mark was looking after the Indian cricket team for a number of years, and this was his picture. He had a horrible varus thrust, and he wanted to get something done about it. Now he knows all the options, and actually Ponky Free had done an osteotomy on the other side, which he was happy with, but he wanted to have something a little less painful, and came up to Basingstoke for his osteotomy. And when I did my follow-up at the Isakos meeting after 5 months, I said, "How are you doing?" And Mark did this and smiled, and he's had the plate out, and he's absolutely delighted with his osteotomy. This is another knee surgeon. This chap works in Jordan, and he had this full thickness chondral defect, varus, and came up for cartilage surgery in combination with an osteotomy. And again, very surprised that he'd had his knee opened, and he'd had the osteotomy, and he was pain-free the day following surgery. So we've done a study looking at what are these bone wedges doing. We've done one clinically. 28 patients were assessed in each arm, and when we looked at the mean VAS scores, the bone wedge patients did much better. But what was really surprising to me was not the fact that there's much less pain, but actually the outcomes. This is a year actually. This should say 12 months. The Oxford knee score and the KOOS was just so much better in the bone wedge group, and that was a surprise to me. And we in that series we had no significant complications. So we've done a biomechanical study with Dietrich Pape. As I say, he's the go-to guy for this, and James Belsey's doing the PhD, and Roman and Dietrich have done the experiments already, and will be publishing that in the very near future. And not surprisingly, the bone wedge does provide significant initial stability. So in Basingstoke, we're close to 1,000 osteotomies now in terms of numbers, and we're following them all. Our DFO series is 172. This is work that I've collected with Chris Wilson from Cardiff and Matt Dawson from Carlisle, and Mike Riesbury and now Sam Yassen are also carrying out cases in Basingstoke. And between us, we're following the cases, and what we're seeing is very similar results for our osteotomy patients to our partial knee replacements in terms of Oxford Knee School, KOOS, and improvement in pain. I'm just going to show one or two slides because we can also apply this MIS technique to the femur. This is again from Hanover. This is Christian Clay's idea, and actually through this window it is possible to do this operation very safely in terms of placing the wires, making the cuts, placing the second wire and creating a cage for the second cut, and you can see the wires going in, then doing again a biplane cut for the same reasons as I described earlier, so cutting the bone 2/3 and then 1/3 ascending, and then slipping the plate in. And Christian came up with this really clever idea, and this is a really fantastic take-home tip, and it's to use a passport cannula at the top for the top 2 screws in terms of putting your drill sleeves and putting your drill bits in. It makes it so much easier to access the plate because you have this cannula. It just makes it so easy to do that top part of the operation. Very similar in terms of what we do for post-op pain and swelling. So really, osteotomy is all about keeping options open. This is one of Neil's patients. She had bilateral osteotomies in '95. She had an ACL with an MCL done in New York. She had the right knee done in 2003, the left in 2004. She was a good friend of David Murray's, didn't want joint replacement at that stage in her life. So Neil then took her nearly 10 years later to bilateral simultaneous knee replacements, total and partial, and here she is, age 59, at 6 weeks, at an appropriate age for those joint replacements. Well, that's running. So this is just something slightly lighter, just 2 slides to finish with. This is to say that it works in the elderly. This is Professor Takeuchi's way of assessing his patients at 3 months. He's done this brilliant study on over 70 and under 70-year-old patients undergoing osteotomy. It's a fantastic study that he's presented and I believe about to publish on. This is another lady who's had an osteotomy, and this is her at 2 months, 81. It's just amazing. And look at this 87-year-old lady doing her rehab at 3 months. And it just makes the point that if it's appropriate, age really shouldn't come into the equation in terms of osteotomy. So we're having our 10th masterclass in December. We're going to do a live femur this time. We're going to do a distal femoral osteotomy to mix it up a bit, and you're all welcome to attend. I'll take any questions. Thank you very much.